Hi, I'm Dr. Kristina Dervaitis. Welcome back to my channel, Talking IUC with Dr. D, my YouTube channel devoted to all things related to intrauterine contraception and answering questions about this method of contraception. So in today's video, I'm going to talk about the very rare complication. So this isn't common, but I'm going to talk about the very rare complication of something called IUD perforation, sometimes also known as migration. Now, in terms of other potentially more common side effects or risks of the IUD, I'd refer you back to my video number 3, the need to know info, in which I detailed the complete list of potential risks versus benefits using the IUD. But in today, we're specifically going to be talking about the situation of uterine perforation. So what is this complication and what does it mean? So uterine perforation refers to the situation in which the IUD actually goes through the uterine cavity. So of course the IUD is intended to be within the uterine cavity. Just if this is sort of my little model here, we're supposed to be here inside the uterine cavity. But for various reasons, which I'll describe, the IUD actually ends up outside of the uterus where it's not supposed to be. In terms of the incidence, again, this is very rare. And although there's been a number of different studies, the generally quoted rate of uterine perforation is about 1 in 1,000. So again, very, very rare. And I want my viewers to put that in the perspective of other risks as well. So looking at the fact that all contraceptive methods, almost all very effective contraceptive methods, unfortunately do have some risks associated with them. For example, the birth control pill has a very, very risk of blood clot or stroke complications. But in any situation where we're using medications, we're weighing potential risks versus benefits. And of course, the risk that we're up against is the potential risk for unplanned pregnancy. And that's what this is all about, is preventing unplanned pregnancy here. And so keeping in mind that half of all pregnancies in North America are unplanned, and of those, around half are due to contraceptive failures. So patients who have used a method and it has failed them. And I'll remind viewers, I know I'm a bit of a broken record about this, but I'll remind viewers that the IUD has a less than 1% chance of pregnancy in terms of typical real world use rates, compared to the birth control pill, for example, which requires the user to remember to take a pill every day and has up to a 9% chance of pregnancy. Typical use rates for condoms up to 18%. And fertility awareness or natural family planning has gotten a lot of press online recently, and the typical use failure rates are actually in the range of about 24%, according to the CDC. So we want to keep all of that in mind. So what actually occurs, or how does a uterine perforation happen? So most uterine perforations actually occur at the time of insertion. And what happens is that for various reasons, which I'll discuss some of the risks, but for various reasons, the actual insertion device, which normally would stop sort of just shy of the top of the uterus, for whatever reason, it actually penetrates and goes through the wall of the uterus, and in most instances could lead to the IUD actually existing outside of the uterus in the abdominal cavity. Now, in some instances, the IUD inserter may recognize, prior to deploying the IUD, may recognize that there's been a penetration or perforation rather, and that they may stop the procedure and not actually deploy the IUD. And in those situations, nothing further may actually need to be done. That healthcare practitioner would talk to the patient about what had just happened, why they didn't deploy the IUD, what signs and symptoms to look out for, such as abdominal pain, dizziness, lightheadedness, and so on and so forth, and would give that patient instructions of where to go in the case of an emergency. But most instances of that sort of a uterine perforation where the IUD is not deployed, actually the defect in the uterine cavity that's created will heal spontaneously and nothing further may need to be done. It would be very rare for there to need to be a surgical procedure in that situation. So what are some of the potential causes? And we're going to talk about the consequences and how we manage that situation. But first, let's talk about some of the potential reasons that this might happen. So in some instances, there may not be any risk factors for perforation, but some of the more commonly mentioned risks are, for example, a patient who is in the postpartum state. So postpartum patients, because of certain characteristics of the actual uterus itself after it's healing from the pregnancy and delivery process, that can potentially predispose to uterine perforation. Similarly, because of some of the hormonal changes during breastfeeding and the effects on the uterus, in breastfeeding patients, there may be a slightly increased risk of uterine perforation. Now, that all is to say that those are potential risks, but I want to emphasize that that does not mean that it is not an appropriate option for postpartum breastfeeding patients. Both the levonorgestrel and the copper IUD are both ideal options for postpartum patients and breastfeeding patients, but it's just something that as a healthcare provider and as an IUD inserter that we are aware of when we're counseling patients and when we're actually performing the IUD insertion procedure itself. Another potential risk factor for uterine perforation would be potential features of uterine anatomy that may predispose to perforation. Now, everyone's anatomy is a bit unique, and prior to an IUD insertion, the healthcare provider is doing an internal exam to feel for the uterine anatomy and to tell which direction the uterus is facing, and so on. But in some situations, for example, if there's quite a dramatically angled uterus in one direction or another, or if there might be scar tissue for various other reasons that might fix the uterus in one position or another, making it a little bit less flexible, those situations might potentially predispose to uterine perforation. Another situation that's quoted in the literature in terms of risk factors is potentially an inserter who might be less experienced at IUD insertions. So like all things and all procedures, the more procedures one does, the more skill set that person might have, and that can certainly factor into the equation. But I want to mention that even in the hands of the most experienced inserter, there is still this potential risk of uterine perforation. It's not something that can be a risk that can be completely eliminated. So those are some of the situations where we might see a uterine perforation, although as I mentioned, in some situations there might not actually be an identifiable risk factor. What happens if there's a uterine perforation, and how can we tell, and how do we make the diagnosis? Now, I will say that many, or if not most, uterine perforations are actually asymptomatic, or the patient may not have any symptoms or potential discomfort. Part of the reason is that the IUD itself is really quite a soft, flexible material, and even when it's present outside of the uterus and within the intra-abdominal cavity, as it might be pushing up against other structures within the abdominal cavity, it's really quite soft, and in many situations, or most situations, will not cause any sort of damage or any sort of discomfort. Oftentimes the IUD may be found just sort of tucked behind the uterus, where it's not really causing any harm or discomfort to the patient. The other feature of our anatomy that I wanted to point out in this situation is that we have something called the OMENTUM, which is a big sort of layer of fat that hangs within the abdominal cavity. It hangs from the bowel, and it is designed to protect the peritoneal cavity or the abdominal cavity from any sort of process that may be causing harm or foreign bodies. So that OMENTUM is designed that if something is there that wouldn't typically be there within the abdominal cavity, it latches onto it, and this fatty layer encapsulates that, and basically protecting the remaining abdominal structures from that foreign body. So that potential protective mechanism also may attribute for the fact that really there may be very few symptoms in the situations if the OMENTUM has essentially grabbed onto and covered up the foreign body, in this case the IUD, and so it's not causing any harm or any symptoms or pain. Probably one of the commonest ways that we would diagnose a uterine perforation would be at a check in the office, a subsequent check after the initial insertion appointment. We do a check and find that the strings aren't visible. Now, I want to emphasize that that does not mean that in all situations where we're not able to see the strings that it means for sure a uterine perforation. Absolutely not. And in other videos, I sort of discuss this and the fact that sometimes the strings can sort of be hidden within the cervical canal. But I would say that if a healthcare practitioner is seeing their patient after an IUD insertion and the strings are not visible, then that would be one thing on their differential diagnosis or list of possibilities, and further investigations would be necessary. Similarly, if a patient previously was able to feel their own strings at home and now is not able to feel the strings, then that might be a potential situation where we're concerned about possible uterine perforation and further investigation is required. Other situations that might alert us to a possible uterine perforation or or an IUD migration or an out of place IUD might be prolonged or unusual bleeding patterns or prolonged or unusual pain. So in those situations, we obviously want to do our due diligence and check on the position of the IUD. And I just wanted to also add that given that in many situations, the actual perforation does not have any symptoms and the patient doesn't necessarily notice anything or have any symptoms or know that anything's wrong, this is part of why I think it's really important for you to follow up with your healthcare provider as instructed and to go and see your doctor for that checkup afterwards, whether it be a month later or everyone practices a bit differently. And I will also say that because of this rare risk and because of the risk also of expulsion, I actually tell my patients to just to be on the safe side to use backup contraception until we've done that check, because of course one of the other potential complications of a uterine perforation or symptoms, if you will, would be potential pregnancy, that the IUD is outside of the uterus and obviously not doing its job or functioning properly, and the patient who is not using any sort of other form of contraception ends up with an unintended pregnancy for that reason. So just keeping that in mind, and again to reinforce the importance of follow-up afterwards. Now, if we're suspicious that there might be an IUD perforation, for example, let's say the situation where we've done an exam and the strings aren't visible, what are the next steps for diagnosis? So probably the very next step that most healthcare providers would take would be to order an ultrasound. Now, after the ultrasound has been done, obviously if the IUD is shown to be in good position, then we're reassured. If the IUD is not visualized within the uterus, then we need to take next diagnostic steps, because if the IUD is not visible within the uterus, there are two possibilities that we need to sort out. One possibility is that the IUD may have been expulsed or may have come out of the uterus, and the patient may not have been aware of that. And there's overall, on average, about a 5% chance of expulsion. So we need to sort of sort out that possibility and decide, did the IUD fall out vaginally and was expulsed, or has the IUD gone through the uterus into the abdominal cavity? So to do that, or to sort that out, usually the next step would be an abdominal x-ray or a flat plate x-ray. And most or pretty much all modern IUDs that are available currently or in Canada are what we call radio opaque, so that we can see them on an x-ray. And so then obviously if we are able to see the IUD on that x-ray somewhere within the abdominal cavity, and we weren't able to see it within the uterus on ultrasound, then the conclusion is that the IUD has gone through the uterus and is no longer within the uterus. In some situations, it can be difficult to tell just based on ultrasound or based on flat plate x-ray, sometimes depending on the patient's uterine anatomy or other factors such as fibroids or other things that may affect the ability to visualize the uterus and the uterine cavity on ultrasound. And in some situations, we may actually order a CT scan for better visualization. So in this situation, let's presume that we've made the diagnosis of the, we haven't seen the IUD on ultrasound within the uterus, but we've done a flat plate and we see that the IUD is still present in the somewhere in the abdominal cavity. It has not been expulsed vaginally. It is there outside of the uterus within the peritoneal cavity. So what is the next step there? So usually to remedy this situation, we would next go on to a day surgery procedure called laparoscopy. Now, before we talk about that, I just want to emphasize a couple of things that patients are often confused about. When we are in a situation where there's a uterine perforation, when we need to go on to surgery to retrieve the IUD, this does not have an impact on future fertility. This does not necessarily mean that the patient is going to have difficulties conceiving. So I just want to address that misconception right off the top. Now, in terms of laparoscopy and having to do a day surgery to retrieve the IUD, it all sounds very dramatic, and I understand when we're in the situation and explaining to patients, they're, of course, upset at the news and upset at the thought of having to undergo surgery. But just keeping the big picture in mind again, and the overall perspective of, the goal here being to prevent unplanned pregnancy. Remember that in patients who unfortunately end up having an unplanned pregnancy, whether they continue with the pregnancy or terminate, there is still the potential that they may end up with a surgical procedure or some sort of a procedure. If you consider that a vaginal delivery even can sometimes require some manipulation or intervention, and we would consider a procedure. About 25% of deliveries currently, or births currently in Canada, are via C-section, so that would be a surgery. If you choose to terminate a pregnancy, some are done medically, some might require surgical termination. So again, it seems dramatic that this is a complication that might require a surgery to correct the situation, but keep in mind that unplanned pregnancy itself could sometimes result in a surgical procedure as well. And this is all about trying to prevent unplanned pregnancy. Okay, so that was just sort of a bit of perspective there. And again, I just want to emphasize that this is a very manageable situation. So it does not have an impact on future fertility, and we can manage this situation by going on to laparoscopy. So a laparoscopic surgery is usually a day surgery procedure, which means you don't have to stay in the hospital overnight if there were no complications with the procedure. The entire procedure usually ends up taking around 30 minutes, I would estimate, again, in an uncomplicated situation. It does involve a general anesthetic, so you're asleep for the procedure and not aware of anything and not feeling anything. Generally, what's involved in laparoscopy, so it's like we would call it a video camera surgery. So we would make an incision. It involves just very small incisions, usually less than 1 centimeter, usually a small incision beneath the belly button area and a small incision just above the pubic bone area. beneath the belly button, we would, one practice is to insert a needle to what we call insufflate or puff up the abdominal cavity with carbon dioxide gas, which creates a protective layer between the abdominal wall and what lies beneath. And through that small under the belly button incision, we would insert what's called a trocar, which allows us to place a video camera through to look around. And then through the lower abdominal, smaller incisions, we would put in another instrument that allows us to manipulate things so that we can essentially look for the IUD and retrieve it through that small incision site. In many instances, the IUD is sort of tucked behind the uterus in what we call the cul-de-sac. It may be encased in some OMENTUM, and we have to do a little bit of dissection work to remove it there. But in the vast majority of cases, it is easily retrievable via this day surgical procedure. Recovering from a laparoscopy, although there is some discomfort, and usually the surgeon would prescribe some sort of analgesic afterwards. In terms of activity restrictions, really the only activity restrictions would be based on the patient's own discomfort. If they are feeling well and able to do the regular activities, no restrictions there. Someone who's working would be theoretically entitled to 1 or 2 weeks off of work, but most patients may find that they're up and back to regular activity much sooner than that. And I will mention this for anyone out there watching this video who might be in that situation where they are postpartum and breastfeeding. I will say that having to have a laparoscopy and a general anesthetic should not interfere with or dramatically interrupt your ability to breastfeed, other than obviously the time that you need to spend at the hospital actually having the procedure done. None of those medications mean cessation of breastfeeding at all. Now, in terms of future contraception in someone who's had a uterine perforation because of an IUD, I do want to note that some patients will actually elect to have a new IUD placed at the time of the laparoscopy, because in that situation we are actually able to do the insertion in a situation where we can actually visualize the top of the uterus and ensure with our own 2 eyes that there's not any sort of a perforation situation. So having a new IUD placed is a possibility, and having one IUD perforation does not necessarily mean that a perforation will happen again per se if you choose to continue to use an IUD for contraception. In some patients who are 100% definitive that they are not interested in any future pregnancies, they may elect to have a tubal ligation or removal of the fallopian tubes. There's different ways of tackling that procedure, which I won't get into here, but they may elect to have some sort of tubal occlusion or removal procedure as a permanent form of contraception. But again, that's a 100% permanent situation, so that patient has to be 100% definitive that under no circumstances would they be interested in future pregnancies. One thing that I wanted to mention here is that I've discussed the situation of complete uterine perforation, or when the IUD has actually gone through the uterus. I didn't spend a lot of time talking about partial migration or penetration or perforation because it's a bit of a different situation. That would be where, instead of being right center within the uterine cavity, some portion of the IUD, whether it be the actual IUD stem or some more commonly the arm of the IUD, the T portion, if you will, sometimes a portion of that can penetrate a little bit into the deeper muscle layer of the uterus, which is different from it going all the way through. And partial penetration is a bit of a subtopic, but I will say that each situation is individualized depending on the situation, the type of IUD, the imaging report, and not necessarily every single partial penetration may require removal. Certainly these don't usually require a surgical procedure to remove. Occasionally a hysteroscopic procedure or video camera within the uterus, but these don't usually require laparoscopy to remove. And again, it's sort of on a case-by-case basis. If the arm is slightly penetrating the muscle layer, it doesn't necessarily mean bad things are going to happen or that the IUD isn't working, and it may not always require removal of the IUD or reinsertion of a new IUD. But so that was just a little bit on that subheading. So that was a bit of a long video, but I just wanted to go in depth for any patient out there or viewer out there who may have experienced this complication and is looking for detailed information. I also want to address that I know that there's a lot of horror stories out there on the internet that unfortunately these sorts of very, very rare but serious complications tend to be the ones that people are reporting online or that the press or the media are reporting on. But keep in mind that this is still a very, very rare incidence, and keep in mind the overall goal that we're up against, which is preventing unplanned pregnancy. And remember that the IUD is one of our most effective ways of doing so. So it's all about weighing risks versus benefits. Okay, so that's all for today's video. I'm going to end, as I always do, by reminding you that in much less than the time that it took for me to you to watch this video, you could have had an IUD inserted. The whole process takes about 5 minutes and can provide up to 5 years of worry-free contraception. Thanks for watching. We will see you in the next video. Take care.